Hi, my name is Lib Slaughter. I'm a nurse practitioner with the adult congenital heart program here at the University of Washington, and we're going to talk today about congenital heart disease and what happens after these children are repaired in childhood. We're going to cover ways of understanding this anatomy in congenital heart disease and review some of the major congenital heart diagnoses and what we watch for in these patients as they age. I just included here kind of a quick little bit busy slide about what percentages of people who have congenital heart disease have these particular different diagnoses, just to give you sort of an idea. So at the top part of the slide are the various really rare stuff, things like double outlet right ventricle, things like TGA, things like double inlet left ventricle, truncus arteriosus. These all occur in less than 1% of all people who have congenital heart disease. So very rare. Then we move on to AV canal defect, which we see a lot in the Downs population. At a rate of about 40% have a AV canal defect. They can also have other congenital heart diseases as well. Moving on to detransposition of the great arteries occurs in 5% of congenital heart disease, and most of them are boys. 3 boys to every 1 girl has this defect when they have congenital heart disease, and it's TGA. Bicuspid aortic valve occurs about that same rate, again with a male preponderance. Tetralogy of flow occurs in 10%. Coarctation of the aorta in 8 to 10%, and the most common congenital heart disease is ventricular septal defect, followed by atrial septal defects. So we'll keep these in mind as we go through some of these lesions during this talk. I included some diagnoses that we commonly see. It certainly is not an exhaustive list. There are a lot of congenital heart diagnoses, and it was hard to include everything in this talk. In terms of the way we classify congenital heart disease, there are a few different ways. This is one of them, to divide them up into those that are blue versus those that are not blue. And so the not blue ones are the ASDs, VSDs, and the PDAs. Some types of tetralogy of flow, where there's more pulmonary blood flow, that can be sort of the pink tet. But for the most part, tetralogy of flow is considered a cyanotic congenital heart disease. And these babies are born blue. The same with transposition of the great arteries, pulmonary atresia, tricuspid atresia, truncus arteriosus. This is just a few of the cyanotic heart lesions. Another way to think about this is according to sort of position in the heart or whether or not they have a shunt. And so I included some different ways to sort of organize in your brain where to put these congenital heart diagnoses. So under shunts, the obvious ones are atrial septal defect, ventricular septal defect, PDAs, atrioventricular septal defect, and that term is synonymous with AV canal defect or endocardial cushion defect. We have about 3 different terms for that. The atrioventricular septal defect term is the most up-to-date term, but mostly when you read notes and things, people are still using various terms, and so just so you know what that means. And then the right-sided obstruction, the lesions that fit there are tricuspid valve atresia, pulmonary valve atresia, and that would probably include pulmonary artery stenosis, pulmonic stenosis. All of these can be congenital problems. And when I think of pulmonary atresia, I think of also not only the valve is malformed or not there, that the pulmonary arteries, the main pulmonary artery and the branches may also be abnormal. In the left-sided obstruction category, there's mitral valve stenosis, aortic stenosis, and this is congenital aortic stenosis. Coarctation of the aorta And in the single ventricle category, there's double inlet left ventricle, double outlet right ventricle, hypoplastic left heart syndrome, which we spent a lot of time on in the last talk. Transposition of the great arteries fits under the D transposition or L transposition. Then we have truncus arteriosus, and I'll explain all of these lesions a little later in the talk. Those that fit into sort of the other category are things like tetralogy of Fallot, which is mostly a right-sided lesion. And Epstein anomaly is definitely a right-sided lesion that has to do with the displacement of the tricuspid valve into the RV, creating an atrialized right ventricle. That's a quick summary of some of these lesions. This is another way that we can think about this anatomy. It's called sequential segmental analysis. And you know, if you type that in, it's actually more complex than just this one little slide, but I thought I would introduce it to you. It's a good way to, particularly to understand some of the more complicated lesions and how people analyze these lesions and come to an understanding of what they mean. And one is the cardiac position, and the apex orientation. Is the apex right or left? Do you have two left atriums? Do you have a right atrium and a left atrium? Is the left atrium switched to the right side? And how do we know this? By looking at the morphology of those atria. So the left atrium has certain features that make it a left atrium anatomically, and the same with the right atrium. So you can usually tell which one it is if you've done an echo, for example. And then the next level is to look at atrioventricular connection. So does the right atrium connect with the right ventricle or a left ventricle? And then at the level of the great arteries, you're looking at whether the aorta connects to a left ventricle or a right ventricle. And then there can be some associated malformations and lesions like coarctation of the aorta, where the aorta is narrow, or pulmonary artery narrowings, collateral vessels, and abnormal coronaries, for example. This is sort of just boiling it down to sort of looking at three different segments. And so if you think about things in that way, it can be a little bit easier to understand these lesions. And then in some of our patients, not only is the heart kind of switched around in a funny way, but so are the viscera. And so in some of our patients, the stomach is not on the right, it's on the left. It can be kind of in the middle. The same with the liver, the same with the spleen. Polysplenia just means it's not just one big splenic organ. They're kind of lots of little bits. And so sometimes you'll see that as well. So just kind of to put that in there, that it doesn't just affect the heart. So one thing to consider is whether just at a basic level, are the AV valves where they should be, like are the atria connected to the ventricles in the usual way, or are they switched? If they're switched, they're discordant. If they're not switched, they're concordant. So a discordant ventriculo-arterial connection means that the aorta comes off the RV and the pulmonary artery comes off the LV. That makes it a discordant connection, not a concordant one. So what does D-loop mean? Whenever you see DTGA, you wonder, well, what does the D mean? Well, it's referring to the embryologic development of the heart. And in a D-looping configuration, the RV ends up on the right where it usually is. And I'll go through some D-loop kind of lesions. So detransposition of the great arteries. On the left-hand side is a picture of a normal heart. On the right-hand side is a repaired DTGA. So the transposition of the great arteries means that the person is born with the aorta coming off the right ventricle, and they're born blue. because all that blue blood coming back through the IVC and the SVC is going out to the aorta without picking up oxygen. So how do we correct that problem? Well, they do a surgery that fits into a category of surgery called the atrial switch. It means they baffle the right atrial blood over to the left side, and therefore the left ventricle can pump the blue blood out to the pulmonary arteries. It picks up oxygen, it comes back through an ASD and is then spills into the right ventricle and pumps that red blood out into the aorta. And this atrial switch repair, the most common one is the mustard or the Senning. You won't see as many Senning repairs because it was a hard repair to do, and one surgeon was particularly good at it, but it wasn't really well replicated among surgeons. And so the Senning uses native tissue to form these baffles, which we call the pants legs, because they sort of look like pants legs as they come in. And the mustard uses synthetic material. And so what happens to these people over time? They end up with right heart failure because the right ventricle is the pump, and it really wasn't designed to be the pump. They get baffle leaks, so where the pants legs are, you can get leaks in there and shunts. The baffles can be obstructed, and so when we do cardiac caths on these patients, that's what we're looking for, baffle leaks, obstructions, to help, we can plug those up sometimes through an intervention, put coils in the leaks, that kind of things, stent the obstructions. They also tend to get arrhythmias. They sometimes have pacemakers where like a transvenous lead would go down, sit in the left ventricle, unlike most people who that lead would be in the right ventricle. And it can be difficult to find paceable atrial material if you have all this synthetic baffle material. So sometimes we have trouble atrially pacing them or putting a lead in like that. Another thing to think about in this lesion is abnormal coronaries. And so you can do, you don't have to think about that so much with the atrial switch, but when you start thinking about the newer repair, which is a arterial switch, where they actually switch the great vessels, it's harder to do and impossible to do if the coronary arteries are anomalous. And so here are some of the abnormal configurations, and if you can't do an arterial switch, you would need to do some sort of RV to PA conduit, so you get that oxygen, that blue blood to go to the pulmonary arteries the way it's supposed to. This is the newer repair that I was referring to, arterial switch repair, which is a Jantine arterial switch is the name of it. You can see that they carve out the coronaries as buttons. They actually cut the great arteries above the valves, and they switch them, and they plug the coronaries back in. And so once they're repaired, then you actually have what looks like a fairly normal great artery configuration. Any questions at this point? No. What happens down the road, we watch the arterial switches who are now just reaching 20. So this gives you an idea, sort of like the extra cardiac Fontan repair. This is a newer repair, and we have some 20-year-olds in our clinic who have had this repair, and we're watching them for coronary problems down the road, narrowing at the anastomosis sites, neo-aortic valves, so dysfunction. So, when they switch the great arteries, the original valves stayed in the normal position. So what now looks like the aorta is actually an older pulmonary valve, and it will sometimes fail over time. It wasn't really designed to be on the left side of the heart with the higher pressures, so that makes sense that it might develop dysfunction. Also, the aorta can develop some root dilation, and so we watch for that. Arrhythmias are common. This population is at risk for sudden death, and seems to be, could be related to some of the repairs, but for the most part, it just seems to be a separate conduction disease that they develop. And of course, they can develop heart failure as well. Even though theoretically the ventricles are pumping the way they should to the right ventricles on the low pressure side and the left ventricles on the high pressure side, and they're pumping in their correct positions, but they still can fail over time.
How old are those kids when they're getting that?
Oh, they get them within the first few days of life.
Oh.
Yeah, so they're getting switched early. This is a really complex lesion. I'm not going to spend a lot of time on it because it kind of makes your eyes kind of go cross-eyed when you start looking at it. It's a very complicated lesion, and it depends on where the VSD is. But I bring it up because it's a D-loop defect. So embryologically, the RV is on the right, the LV is on the left. And basically, if you think about it, both great arteries are more kind of on the right side above the right ventricle, if you think of it that way. I'll show a picture in just a moment, but it's often associated with other lesions like VSDs, pulmonic stenosis. The great arteries are switched, at least some of the time, and the aorta is more closely related to the RV instead of the LV. There are some of these patients go down a 2-ventricle repair pathway. Some do not, and it depends on where that VSD is located and how the great arteries are related. Here is sort of I find this picture helpful. The top is a normal heart. All the other 4 pictures are the various versions of this lesion, and they all are classified based on where the VSD is located. The vast majority of them are either subaortic VSDs or subpulmonic VSDs. The subaortic VSDs act more like tetralogy of Fallot. The subpulmonic VSDs act more like transposition of the great arteries. And these lower types are more rare, and the non-committed VSD often goes down a single ventricle pathway, meaning Norwood, bidirectional Glenn, Fontan repair, okay? So here I just sort of summarize that the subaortic VSD behaves more like tetralogy of Fallot, and the repair is similar. It's a patch to the right ventricular outflow tract to sort of help open up the flow to the pulmonary arteries. The subpulmonic VSD type behaves more like a transmission of the great arteries, and the repair involves an arterial switch. And the doubly committed VSD, which was the lower left-hand picture, those people kind of get repaired more like the subaortic version, and the non-committal is a single ventricle type repair. They just can't get away with the 2-ventricle repair in those patients. I wanted to move on to the L loop and what that means. Again, it's an embryologic kind of development, and at the end of that, the LV always ends up on the right side. So the ventricles are switched. L transposition is a totally different thing from D transposition. And so I bring this up because when people read congenitally corrected transposition of the great arteries, that's actually the term that you'll see in much of the older charting. When you read that, it looks like something was surgically repaired. Many of these patients have not been surgically repaired. In fact, we diagnosed a 60-year-old with this. He came in some heart failure. He had never been diagnosed with a congenital heart problem. these patients don't necessarily need surgical repair early on, and many of them haven't been repaired or even discovered. So typically the left ventricle, it means ventricular inversion, meaning the LV's on the right, the RV's on the left. That's typical of LTGA. The great arteries can be switched. In this case, the congenitally corrected means that the blue blood is going where it's supposed to go and the red blood's going where it's supposed to go. But what's wrong with this picture is the RV ends up being the pump, and the RV can fail over time. They also, many of them get heart block, and they can get SVT, and that might be the first time they come to medical care, is they develop a heart rhythm issue. We do the echo and we go, oh, that's not normal. The AV valve tends to fail. And so when you think about these patients and you think, well, the LV's on the left, so what do you call that valve? Well, generally it follows the rule that and morphologically, the mitral valve will follow the LV. The tricuspid valve follows the RV. So if you go by that rule, the AV valve follows the ventricle, then you can figure out what to call that valve. So in this case, on the right is the mitral valve, okay? As I mentioned, they get pacemakers. Sometimes we'll close the VSD if they have a VSD. They might have pulmonic stenosis. We can either balloon open that up. Maybe they get a patch across the valve, and they get treated for heart failure. They might need a AV valve replacement. Not going to spend a lot of time on this one because we spent a little bit last week, but this is one of the single ventricle diagnoses. And it's the one where, unlike double outlet right ventricle where you see this big RV, instead where you normally see the RV in that lesion, in this lesion it's a big LV and a small RV. And the big arteries come off the LV. And the LV is on the right side. So that's something to remember about double inner left ventricle. The left ventricle is usually on the right side. The ventricles are inverted. And it makes it L-loop lesion, right? Moving on to right-sided lesions. So I think of this as a right-sided lesion, but it actually has four different problems. Tetralogy of flow means tet means four things. And it's really that the aorta overrides the VSD into the right side. You can see here the VSD's here and the aorta sort of straddles here. The pulmonic valve is narrow. The right ventricle is hypertrophied, and there's a VSD. Those are the four things that make it tetralogy of Fallot. When they're repaired in infancy, they typically do a transannular patch across the pulmonary valve, and there's often free pulmonic insufficiency. The thinking is rather than try to put some valve in there that has to be replaced after they grow each 2 years, they leave not much valve tissue there at all, and they let them grow. And they typically tolerate this free PI for a long time without a lot of problems. They can run around, they function as pretty normal children. But as they get into adulthood, the RV starts to get big and it starts to fail. And so then we need to put a valve in there. And so when we follow these patients, we're doing MRIs to monitor our RV volumes. And after they get, to a certain size, we go ahead and repair them and put a pulmonic valve in, because you don't want to wait till it's beyond the point of no return in terms of the enlarged RV. Sometimes these RVs won't shrink down after a certain point. And what is less obvious about this is, while this seems like a right-sided lesion, we also follow them for dilated aortas and left ventricular dysfunction, because they can develop that. And whether or not there's an aortopathy that could be associated with tetralogy of flow, we aren't sure about that, but we have seen this in a number of patients they turn up with aortic aneurysms, and so we watch for that as well when we do an MRI. Arrhythmias, tetralogy flow patients are at risk for sudden death, and so we do a lot of Holters. If they start talking about palpitations, then we want to know what they are. Anything beyond single beats. If they describe runs, they're getting a Holter or event monitor, and we're trying to diagnose it. Moving on to left-sided problems. The bicuspid aortic valve, something you're probably well aware of. It is a congenital problem, and it is associated with aortopathy, and some of these patients have coarctation of the aorta, so they have more than one left-sided lesion. And so we're really watching them for progressive aortic valve dysfunction. Other diseases of the aorta include Marfan's. This is a genetic disorder. Louis-Dietz may be a condition you haven't heard of. It actually refers to the same tendency to aortopathy, but it can occur all over in the head, in any of the arterial blood vessels, and it's actually a highly hereditary disease that's passed on at a very high rate. And I've met whole families with this. A child that I know of died at Children's in the CT scanner because he blew an aneurysm in his head, and we were looking at his aorta. So sometimes we don't know about all of the lesions. And in talking to this family, he had like 4 or 5 other siblings that had the same disease. So you can imagine what a huge burden this is on people to find this out. So we follow these people very closely, and when we do MRIs, we don't just do the ascending aorta, we do the aorta all the way down to the iliacs, because we're looking for aneurysms. I included this Ross repair because this was a repair that was pretty popular at one time, like maybe 10 years ago. And it was thought that if you retained if you replace the aortic valve with a native pulmonic valve and put a bioprosthetic valve in the pulmonic position, that maybe the aorta would grow and everything would grow more normally, and you wouldn't eventually have as many problems down the road. Well, it turns out that neo-aortic valve does fail, and these people have ended up in adulthood being very complicated to take care of because they have they have 2 valves that aren't working. They often have double prosthetic valve replacements. They have coronary disease and occlusions because of that original surgery, and so they're complicated. So just to kind of be aware of the Ross repair. The Bentall repair is something you've heard of, but if you look at how this repair is done, it is coronary buttons that are plugged in again. So you just remember that, like, transmission to the great arteries, where we're switching things and moving coronaries as buttons, that they can occlude and develop problems. So coronary artery disease is something we need to work on or look for. Coarctation of the aorta. So the early repair was a subclavian flap repair, and I'll just move on to a separate side. So you can see where the top picture is where a typical coarctation occurs. It can be a discrete narrowing, or it can be sort of a long tubular narrowing. When it's that discrete narrowing in that location, what they would do in the old days is they would take the subclavian artery, turn it down, and make a patch out of it. Well, the blood pressures in that arm are no longer normal. So if you take a blood pressure in a subclavian flap repair, you'll get a lower than accurate blood pressure, and it will seem like they have a normal blood pressure. As soon as you do the right arm pressure, sometimes they can be very hypertensive. The right arm pressure is the real one. And so this can fake you out if you do left arm pressures on a coarc patient who's had this type of repair. Likewise, the left arm pressures can be off if you have a narrowing here or below. this pressure will seem lower because it's not getting as much perfusion, right? So that arm pressure will be lower, but the right one will be the accurate one. So a general rule of thumb is that in coarct patients, right arm pressure is the accurate one, okay? And we do 4 extremity blood pressures in these patients to figure out if they're having a recurrent coarctation. Newer repair is this, I don't think I showed the end-to-end anastomosis. Oh, yeah, yes, I did. Here it is. This is the end-to-end anastomosis. So we're not turning down any subclavian artery. We're just chopping out the narrow part and putting it back together. And those can develop narrowings at the anastomosis site. So we watch for those. And ballooning the narrowing open is not usually a very permanent fix. So we're actually stenting and ballooning now. And
I don't understand why you just take out the subclavian artery.
that was the old repair.
So they don't do that anymore.
No.
Because how, I guess I need a recap of my anatomy, like how was the left arm perfusing if you're taking out
The less subclavian perfused the left arm.
right, and they're taking it out.
Right. So you still have collateral vessels and things that feed the arm.
feeding
Is
it.
that your
Yeah,
question?
yeah.
Yeah. You still have blood flow to that arm. You don't just cut off the blood flow,
Yeah,
but
yeah,
it's
yeah.
collateral vessels take over, but it's just not an accurate. It's okay to take the blood pressure there. It's just you're not getting good information. Does that make sense?
Yeah.
Yeah. This is just a bit about recoarctation. If ever you have left ventricular function that's deteriorating in a coarct, that's a later sign. Like you kind of missed something for quite a while. And sometimes people, like kids that present that haven't been diagnosed with coarct yet, that they might present in florid heart failure. And you do the echo and the imaging, and you see, oh, it's the aorta, you know. And when you open up the aorta, miraculously the LV recovers. 'Cause it's working against a big obstruction, right? You find coarctation in hypoplastic left heart syndrome a lot, and so we're looking for that in kids a lot with HLHS. About 40% of them, 30 or 40%, have coarcts. And if they don't have them initially, they develop them as they go along. So it's usually something we know about within the first year of life. But there, left-sided lesions can often be associated with a coarct. Turns out double outlet right ventricle also, a number of those have coarctations. VSD coarctation might be a combination of lesions that you see.
What's the reason that they develop coarct, the hypoplastic?
Unknown. It's a left-sided lesion, so aortic valve is malformed. Sometimes the mitral valve is malformed, and then that translates into the other. And it's embryologically determined, like how, if it's all a left-sided lesion, it makes sense it could be any of the left-sided structures that are affected.
So it's not a hydraulic reason that they develop it, it is a congenital reason?
I think it has to do with the wall of the aorta. I don't think we know exactly, but I think it's the way the wall of the aorta is formed, and so it has some, definitely where the PDA tissue comes in, that common area, you can get coarctation wherever in the aorta, but that one was a more common place. And the PDA comes in there. So you figure when that tissue is thought to be kind of unusual right in that area, because when you're born, the PDA closes. So maybe there's something about that tissue in the aorta that tends to narrow down too. It like goes a little too far. It not only closes the PDA, but it like narrows down right there too. So they think there might be something about that tissue that's different, because that's a common place. But like I said, you can get narrowings anywhere all the way down. That's just a more common one. Truncus arteriosus, this is a rare one. This is one of the less than 1%. You won't see very many of these. But what it means is this trunk, it's basically one great vessel that comes off of a VSD, and it's straddling the RV and the LV, more or less. Mostly coming off the LV. These patients have to be repaired, as neonates. And basically what they're doing is they're separating the pulmonary artery from the aorta, because the pulmonary artery is coming off the aorta somewhere. It might be right near the root, it might be further up, so the position kind of changes. It could even be in the descending aorta, which is odd. But so there are these different types based on where the pulmonary arteries come off the aorta. But basically what you're having to do is create an RV to PA conduit in order to get, and you're closing the VSD. So you patch the VSD, you create an RV to PA conduit, and it's called a Rastelli repair. And the problem with this in infancy is you can imagine that this synthetic material for the RV to PA conduit doesn't grow with the child. So these patients have had 5 and 6 surgeries by the time they come to this hospital. They outgrow them as they grow, so they need surgeries every time. And they're mostly valved conduits, so it involves the pulmonic valve, and that's being replaced as well. So here's another picture of a truncus repair.
Like how many of those patients would you say you have in your clinic?
Good question, but let's just say we don't see a truncus every week in our clinic. We might see one once every couple months. You know, it's rare, but we have a collection of them. When they're children, when they're children, if that aortic valve is bad, then they do more poorly. Like, let's say they need a truncal valve early on. They don't do as well. They just got to have that replaced too every, you know, it's these really complex surgeries. So that truncal valve might be good in childhood, but then it may fail over time and have to be replaced. We talked about the RV to PA conduit replacements. Some of those are candidates for a Melody valve in the cardiac cath lab. Have you heard of a Melody pulmonic valve? Those are the percutaneous pulmonic valves that we're using in congenital heart disease. And so if you have a conduit with a landing zone, you might be a candidate for this valve. So much like a TAVR, this is a pulmonic valve that you can put in, and they basically stent the conduit, and then they put a stented pulmonic valve in. But for tetralogy of Fallot, where you need a pulmonic valve, we're not putting Melody valves in the native position yet, because you can imagine these RVs are all different sizes. The right ventricular outflow tract has varying size patches. It's not as good of a landing zone, and I think while it's coming, it's definitely not prime time that we're putting Melody valves into the native position yet. But if they already have a conduit, they may be a candidate. If it's a super big valve or a super small valve, then they might not be able to do it. So not everybody is a candidate, but it's something we always discuss. Ventricular enlargement and fit failure are a problem in this population, as well as arrhythmias. I'm going to sort of finish up by just reviewing ventricular septal defects. There's a lot of different positions of these defects. The muscular defects are less conducive to surgical repair depending on how big they are. We even have some patients in the population that are called Swiss cheese because they have multiple tiny VSDs that we really can't fix. As they get, and depending on how many of them there are, some will close in childhood. The muscular ones are the ones that are most likely to close in childhood. And if there's a bigger defect that's still open at the age of 5, sometimes we'll go and surgically close it. The perimembranous defects are ones that we tend to close by the age of 5, because if we don't, sometimes it starts to affect the aortic valve. And so now you have more than one problem. Same with the subarterial defects. Those tend to need to be repaired. Atrial septal defect, there's a number of different kinds. The secundum atrial septal defect is the one, this yellow one here in the middle. That's the one that we're able to put a device in the cath lab. Depending on if there's enough tissue around the hole, if it's right near the wall of the ventricle, the atrium, there's a risk of erosion. So they aren't able, so you'll see that there wasn't enough rim, they'll say, then you know that's why they couldn't close it, it just wasn't in a good location. The primum defects tend to be associated with atrioventricular septal defect, where that defect they have ASDs and VSDs. They're more closer to the valve tissue. Those don't lend themselves to device closure usually. The sinus venosus defects, this high one at the top near the SVC, those are highly associated with anomalous pulmonary veins. So often when you see that a sinus venosus defect has been repaired, there's also pulmonary vein repair as well. And the coronary sinus defect, I haven't seen this one a lot. I'm not going to comment on that one. So that pretty much in a nutshell gives you a huge smattering of, and again, it's only a fraction. There are things I didn't talk about, like Ebstein's anomaly. The very last slide here is just about some of the acquired heart disease that you might see in adults, and I only included a picture of Kawasaki disease. These are the giant coronary aneurysms that happen as a result of Kawasaki disease in childhood. This is a febrile disease that folks get. They sort of go through this high fever, they get a skin rash, there's a certain clinical picture, and that will win them an echocardiogram at that age, and we will see are their coronaries affected. And if they are, this is the worst case where they get these giant aneurysms and they need coronary bypass surgery at a young age. We will sometimes follow these for a long time. They'll be anticoagulated. They get lots of imaging to follow these. They aren't necessarily bypassed, but if they develop big clots in them, for example, then they're going to have to undergo through surgery. There are much milder versions of this as well, where they just have some abnormality that you see. They're mildly enlarged, but they aren't huge like that, and they don't ever need repair. But I wanted you to know what Kawasaki disease is, have heard of it before. The other things, endocarditis is something you see in the adult population. Myocarditis, we all know that can lead to a heart transplant if it's bad enough and they don't recover their heart function. Pericarditis is more transient, but all of these things you can get in childhood, but they're not congenital.
Is Kawasaki, is it usually only in the left?
Kawasaki is usually only coronary, not just left coronary, any of the coronaries, yes. That particular picture was left coronary, but